Do you want to put the presentation up? Hi everyone, my name's Tori Hadaway. I'm the Community Children's Wheeze and Asthma Nurse in Tower Hamlets. So I'm going to present the session today. So we will be looking at how specialist asthma nurses have been supporting the 3 Ask About Asthma and some of the issues that we've had around COVID. If we can move to the next slide. So first of all, just wanted to do some housekeeping. If we can please make sure that everyone's cameras are off and that you're muted. This will help with the flow of the presentation. If you have any questions that you need to ask desperately, then please raise your hand. But we are going to have question and answer sessions towards the end. So please, if you can use the chat facilities so that we can gather all of the questions towards the end and then hopefully answer them. If we're unable to answer any, then we will try and answer those and feedback to you after the session. And we want you to know that the session is going to be recorded as well, just so that we can share that with other people that couldn't attend the session today. Next slide. So first of all, we're going to have Pippa discussing with us about biologics and home care and how that service has changed due to COVID. Then we're going to talk to Anika and Alison about their role modelling clinic. And then finally, Natasha, who's going to be discussing about the 48-hour triage service. Next slide. So we're all here today because we want to support hashtag AskAboutAsthma. So if people can Twitter the session, that would be really great, just to spread the word. And we also want to make sure that we're concentrating on 3 areas, and that's making sure that all children have an asthma plan and that they're using their inhalers effectively, and they have an annual asthma review. And I know a lot of us within our daily practice will be focusing and concentrating on these 3 asks. So hopefully we can see what other people are doing in different areas to actually meet these. Next slide. So I think Pippa's going to talk first.
Pippa, you're on mute at the moment.
Right, is that showing in as a slideshow view for you guys?
Yeah, that's great.
Yeah,
that's fine. Lovely, thank you. So thank you very much for the introduction and for asking me to present our paediatric biologic home care service today. Just want to say that much of the hard work in developing this service was done by Angela Jamelsday, one of our clinical nurse specialists, and our difficult asthma pharmacist, Sukeshi Makasha. Angela sadly can't be here today. She's on annual leave, so I'm presenting on her behalf. So first of all, a bit about our biologic service pre-COVID. All patients who were for consideration for biologic will have previously gone through our difficult asthma MDT assessment, and only those who we felt there were no other significant remedial factors contributing to their poor asthma control would be considered. It's always an MDT decision. We'd then, once we decided to start a patient on an MDT, we would bring the patient up to clinic and we would discuss with the team and the named consultant an information pack given to the family. We'd then arrange a start date, and we'd always administer the first 3 doses on the ward due to the longer observational period, and also just to for safety reasons as per our hospital guidelines, just to check for any adverse side effects. Then all subsequent injections on the basis that we haven't had any issues in the first 3 months only required a 1-hour observation period, and patients then started to attend our nurse-led biologic clinic, which was held on a Thursday, so just 1 day a week. We'd ensure that our patients were regularly reviewed with a consultant every 3 months, and then with every monthly injection, we'd carry out the monitoring assessments such as spirometry, exhaled nitric oxide, the quality of life questionnaires, asthma control test, as per the monitoring guidelines. So in mid-March, COVID hit us, and to immediate effect, we were severely limited in the number of children we could bring up to hospital for face-to-face assessments. Also, families didn't feel safe travelling and attending to the hospital either, so we had to consider an alternative way to administer the injections. At this time, Homecare was not set up for paediatrics on biologic treatments at all. We needed to source a home care provider fairly quickly who was happy to take on this agreement as soon as possible. Our adult service had already transitioned all their biologic patients to home care, but they didn't provide any face-to-face training, and patients independently had to read resource packs and watch videos and basically teach themselves. And we really felt we needed to provide our paediatric patients with far more support. There was no existing competency documentation for us to use as a template, and as far as we were aware, no other paediatric home care paediatric service has set up home care for biologics. So we were really starting from scratch. This was back in March. So we luckily managed to find a home care provider to take on both our Zola and MIPO contracts.
Pippa, sorry to interrupt. Your slides haven't moved on.
Oh.
Are you moving them on at your end?
Yeah. Sorry.
No, that's fine. I wonder why that's happening. Shall I share my screen? Yeah.
That is really bizarre. Hang on. Should I just try sharing my screen again?
Yes, maybe try once more.
Sorry about this, guys.
It's all right, technical hitches.
No, wrong one. Oh, wrong one. Oh, here we go.
The baby, yeah. Middle one. That's back. Atrovent and Dex.
Right, can you see it now? Can you see it now?
Yes, it's not in slideshow, but we can see it.
So I've ended it.
Yeah, you go to slideshow.
Slideshow from the beginning.
Yeah.
Is that working now?
We can read it. I think that's probably fine. You go ahead.
Pippa, if you change the display settings, it should, if you go to display settings at the top, yeah, click that down and just says swap presenter view and slideshow.
Oh, there you go. Is that better?
There
Yes.
you go.
Thank you, Emily.
Thank you. All right. So let's get going. So thank you very much. I think I've done that slide. I think I've done that slide. And then done. So yes, so I think this is where I got to. So we quickly identified a home care provider to provide our Zola and MIPO contracts, and we then had to identify patients who were suitable for home administration. This was very much a multidisciplinary team decision. We agreed as a team who we felt would be suitable, and then we contacted parents and invited them to attend for a one-to-one face-to-face training session. We then advised going forward when their injections were due and advised that they would all be undertaken by a video call with them. Initially at the time, there was no standard virtual software that our hospital was using, so we used whatever was available to us at the time, so FaceTime, WhatsApp video call, but basically whatever we felt was helpful for our families. So at the start of the pandemic, we had 25 patients on a biologic. We immediately transferred one of our patients back to Gibraltar. Another was transferred back to Leicester, their hometown. we then had 6 patients which we felt weren't suitable for home delivery, either for safeguarding issues, or they were on a dose of MePO which wasn't licensed for home care. There were behavioural issues and needle phobia. We had one patient who had very mild allergy reactions previously, and we felt that it would be safer for her to stay having it done in the hospital. We arranged for 2 other patients to have their biologics administered by a local CNS. So in all, we had 14 suitable for home care, self-administration by themselves or their parents. So overall, that was 70% of our patients receiving home care administration. So the way it works, to briefly outline the healthcare service, the patients initially attended for one injection face-to-face. During that sort of appointment time, we completed a competency check, we organised registration and a prescription form and gave them an information pack. And then those who had good lung function technique, which was most of them, we were lucky enough to have the facilities to issue them with a home spirometer. We used Nouveau Air and advised them to carry out remote spirometry prior to subsequent administrations of their biologics, much as we would have got the same information when they had come up to the hospital. All families consented to this 2-weekly or monthly call to coincide with their injections. And at the time, we made them aware that this would be for the foreseeable future. And we also did reassure parents that if there were any concerns of injection technique or they had concerns, we would be able to offer them a face-to-face if necessary. Throughout the pandemic, we did have the facilities to bring up a very small number of patients each week if needed, you know, across the whole respiratory department. So that was there if we needed. At each monthly video call, we tried to carry out all the same assessments as we would have done, monitoring assessments that we would have done if they were coming for a face-to-face. So the quality of life questionnaires, the asthma control tests, questions about courses of steroids, unscheduled care visits, etc., etc. And as I said earlier, we were able to complete spirometry, and we could also carry out reversibility if we felt that it would be helpful or they had low lung function. We were lucky enough to have psychologists as physiologists as part of our team who assisted us with the lung function spirometry aspect of this. So the home care currently is continuing. Families are still happy to receive video calls and all are remembering really well. The hospital around about the end of April transferred most of our virtual appointments to Attend Anywhere, and that's what we're using now to do our biologic home care calls. Occasionally we might need to move to an alternative platform, but on the whole it's Attend Anywhere now. Most patients are using the spirometer, the Nouveau Air device well, and they're finding it easy to use. Patients are very happy completing the questionnaires during the call as well. And there don't need to be any issues with the delivery of their biologics to their home. And then again, we're still ensuring that our patients are having 3 to 4 monthly clinic appointments via Attend Anywhere or face-to-face, particularly if their control is, if we've got any concerns about them. And that's what we were doing in the past. So the only difference really is they're having their injections via a video call remotely, and then having a 3 to 4 monthly review with the consultant or medical team. So the service has been going really, really well, and we're really pleased with how it's gone. Obviously, there have been a few teething problems, but the main things that we think are definitely the pros to this service is the reduced burden on having to get our patients coming up to the hospital. Lots of our patients live a long way away, and it involves them having in some of our patients a whole day off school. We were also just doing our biologic nurse-led clinic on 1 day a week. So now we can schedule our biologic calls to be any day of the week, and it's really easy to fit them in after school now, especially as there's no travel up to the hospital. For some patients, initially parents were giving me injections for our older children, but it's great to see some of our older teenagers taking on this responsibility. And this is really good preparation for when they transition across to the adult care, and they will have to be doing it more unsupported on their own anyway. Families are definitely keen to continue home care as it's quicker, easier, more convenient. And I think we have really clearly demonstrated that home care is possible and can work. There have been a few teething problems. We had one problem where the parent didn't administer the injection correctly, didn't push the plunger in properly, and we weren't entirely sure that the child got very much of the dose. So that was one incident. And then we had another parent right back in the early days. She was very, very nervous, and she accidentally pulled the plunger out of the syringe. We saw it happen, you know, at the time, but we were able to really quickly arrange for another injection to be collected by the family, so the child didn't miss out on the dose. Obviously, the benefits of face-to-face contacts have gone. And for some patients, it is useful to see them face to face. So that's a shame that we're not seeing them as often. But I have said that we will continue to see patients face to face if needed. And we did have one family who returned to hospital administration due to safeguarding concerns. So at the time we were starting to set up this service back in April, we did have a sort of ask around to find out what other hospitals were doing, and ultimately very, very few other centres were doing self-administration, and no one was doing video calls back in April. So ultimately, probably what's the most important thing about all of this is the patient's experience and how they view the service. So a month or so ago, we did a little bit of an audit, and we asked our families how they felt the service was going, and it was basically all very positive, and you can see some feedback here. So one patient said changes to the service was really quick and smooth. It was helpful having a video call, saves time on travel. Another one said video call was necessary. They found it really helpful. It was really good having a home lung function, and they thanked us for setting it up. Other parents understandably did say they were nervous at the beginning, which contributed to breaking a syringe and to sharp bins, but they did feel really supported, and especially by the video calls, and no problems with the deliveries working well. Another parent said it would be strange going back to hospital care. This really saves time, and we're missing less school. And then this came from a patient and a parent, said, initially, we really weren't keen as we don't like needles, but the nurses made it far more comfortable. Communication with the home care team was useful. Deliveries on time, text reminders also helpful. Nurses were really nice and very patient. Helpful to have lung function machine, which helped us with awareness of health. And then our final comment is just someone saying how thankful they are for what we've done and how the change in service has really helped them. So yes, it was all very positive feedback. So the future for the service, and where do we go from here? Well, currently we are very much continuing with home care for those now established, and we will continue to offer home care for any future patients once established. And actually we have had one patient commence a biologic since lockdown. They are still coming up to the hospital for their injections because they're still in the first initial trial period, but we will definitely be thinking of switching them across. Continuing CNS calls when injections due also ensures directly observed therapy, ensures that our patients are definitely getting them. And I think it's really vital to continue having that regular contact face to face, albeit over a video screen. Obviously, we carry out the nursing assessments, asthma control tests, but it's an opportunity for us just to keep an eye on our patients as we would have been doing previously by seeing them face to face. And I just want to say on behalf of Angela and myself, thank you to everyone in the difficult asthma team with the management, setup and development of this service. And finally, I'm really sorry about the problems at the beginning with the screen share. I'm not very good with technical stuff, but thank you.
Thank you very much, Pippa. It's nice to see that even after with what's been going on with COVID, that you're able to make positive change for children and family and actually change the service. So that's a really positive thing to come out of that. So I hope everyone can hear me.
Yes, you're fine, Tori, carry on.
My picture's frozen, so I'm thinking no one can hear me.
No, we can hear you.
So I think if you can put up the presentation for the next one, then we can ask Pippa some questions at the end. So I think some people want to know about some lung function. And I think Alison's going to talk to us next.
Okay, thank you, Tori. we're going to, both Annika and I are going to share our experience of the asthma role modelling clinics that we have put into place in the Borough of Hillingdon to date. So next slide, please. Hopefully this, yeah, wonderful. Okay, so what we hope to talk about and endeavour to share with you is what actually are the role modelling clinics that we've put into place, how we've structured the clinics, the financial support which is behind them, which is obviously key and very important to all of us trying to set up new services, where we've got to date and achieved so far, the practice nurse feedback that we've had, as well as the patient feedback, and the next step that we've really implemented really in the last 2 to 3 weeks of trying to create a keep in touch forum, and how COVID-19 has impacted on the clinics that we have been able to put into place. So one of the reasons in terms of background in relation to why we felt this was an important step to take within the borough is that during the last 3 years or so, we have had community nurse specialist clinics running within GP practices spread across the borough. And one of our clinical nurse specialists in respiratory care has been out to run those clinics. So there are children identified as needing further input than that in primary care. And as a result of that, we realised very quickly that it's quite difficult for practice nurses, whilst they had the offer to come and sit in on those clinics and shadow one of us and learn from that experience, getting the time to actually do that is really tricky for them and an extreme challenge. Hard for them to get to protected time, and also for them to be released for a period of time for that to happen. So hence the reason we decided to embark on role modelling clinics. And the idea behind it was to try and upskill practice nurses in undertaking paediatric structured asthma reviews and the ongoing management of childhood asthma within the primary care setting. So one of the respiratory nurse specialists works alongside a practice nurse in the GP practice, so that practices patients to review the children with asthma. The clinics are run on a 6-weekly block basis, so each practice will have 1 clinic per week for 6 weeks. The clinic structure has been set up so that on weeks 1 and 2, the teaching happens from the specialist nurse. So the clinical nurse specialist will actually do the clinic, undertake the structured reviews in terms of being that role model for the practice nurse to sit in and listen and hopefully learn from that experience. Each consultation is set at 30 minutes per patient, which, as we will all be aware, is over and above what normally happens within primary care. At week 3, the practice nurse then takes the lead in the consultations with the support from the specialist nurse remaining in clinic. Initially on week 1, there is an hour's teaching session, which is led by the clinical nurse specialist with the practice nurse in terms of referring them to documents like the London Asthma Standards, the North West London guidelines that we have in place, and our borough approach to asthma management in children generally throughout schools, secondary care, and what we're aiming to achieve in primary care. And during the 6-week programme, we also have an MDT session with the practice staff, so that the GPs within the practice, the pharmacists that may be linked to that practice, along with other practice nurses and the practice manager also, if they are able to attain. So week 6 is our final week, and there is not only obviously the patients being booked in, but we also have an opportunity at the end of the clinic for feedback and debrief regarding what's happened during the clinic experience and how that practice nurse is feeling and has developed during that phase. So in terms of financial support, we were very fortunate that our CCG within the borough was willing to allow us to develop a business case, and this was presented to the commissioners and the Hillingdon Confederation delivered the service once it had been commissioned. The funding itself, we were able to agree that there would be backfill for the practice nurse time, so there wasn't any cost per se to the practice directly, and our CCG funded that financial perspective, and that equated to £30 an hour for each practice nurse to attend those 6 weeks, which equated to £720 per practice over the 6-week period. Additional funding was awarded for 0.5 whole time equivalent band 7 respiratory nurse, and that equates to approximately £10,000 for a 6-month period. And the project management to support the scheme, £20,000 per annum. So our ambition was to achieve whole practice coverage in Hillingdon over a 2-year period. I'm now going to hand over to Annika, who's going to go through some of the results in relation to where we've got to so far.
So thinking about what we have achieved so far, so we've had really good levels of practice involvement. So clinics have been completed in 6 practices and in progress in 4. Actually, this presentation was made about 3 to 4 weeks ago. So now we've completed clinics in 10 practices. We've got another couple running at the moment and another couple scheduled for October. We've had really good rates of appointment acceptance, so nearly 90%, and generally quite low DNA rates. However, unfortunately, they have been skewed when we've had double appointments for siblings who've been booked into the same clinic. So, as Alison mentioned, to assess the efficacy of the clinics, the nurses completed a pre-course questionnaire and a post-course questionnaire. So one was done on week 1 of the clinics and the other one was done on week 6 of the clinics. So in terms of the pre-clinic questionnaire, we can see that 30% of practice nurses were not currently seeing children for asthma reviews. 20% were not following a structured asthma review and reviewing patients, and under 50% were actually aware of the North West London Children's Asthma Guidelines. And we also asked the practice nurses about their concerns when reviewing children, so that we could address them during this block of clinics. So we could see that they were worried that they hadn't had any formal training, they were worried about their inhaler technique, and they were worried about changing medications, upskilling medications. So thinking about the pre and the post-clinic questionnaires again, we can see that confidence in reviewing children with asthma really increased in all age groups from 5 to 18 on the post-clinic questionnaire. We also looked at other domains, so practice nurses felt that they'd really learned new skills, that the trainers, so the hospital asthma nurses, were really skilled, really knowledgeable. And what was really interesting was that they said that this would really help when reviewing adult patients with asthma as well. We also asked about domains like asking about adherence to treatment, asking about acute episodes of asthma, checking inhaler technique, providing written asthma management plans for the patient. And again, as we can see on the post-course questionnaire, practice nurses were all much more likely to do this. They were also more likely to use formal asthma control assessment tools like the Children's Asthma Control Test. And of course, patients are the centre of the clinic, so we want them to have a good experience. So patients were generally really happy with the fact that they were seen in a joint clinic with the practice nurses, the hospital respiratory nurses. They were really likely to recommend this clinic to friends and family, and they were really happy with the information given to them. And then there were additional benefits to these clinics. So something that was really important was that strong relationships were built between primary and secondary care. So there was really good rapport built between the practice nurses and the hospital asthma team. Obviously, they were doing clinics together for 3.5 hours every single week for a 6-week period. It meant that practice nurses had better knowledge of referral pathways, contact numbers for the secondary care team. So, for example, if they wanted to have a patient discussion or if they were concerned about a patient, they could pick up the phone and call the respiratory team. And I think vice versa. So if, for example, one of the hospital nurses is worried about a patient in A&E or that they've seen in clinic, They may feel more comfortable to pick up the phone and call the practice nurse that they know and have a discussion with them about the patient and their ongoing management plans. We also saw practice level changes, which was really positive. So some practice nurses, despite not perhaps seeing children with asthma previously, had become the practice asthma leads following the clinics. In Hillingdon, we use an electronic system called EMIS. So the personalised care plan from Asthma UK has been uploaded onto all surgery EMIS systems where we've done the clinics. We also used a structured review template when doing the clinics, and they've also been uploaded onto the surgery records so that GPs, practice nurses can use this structured template going forwards. We also made sure that acute emergency equipment was checked in practices, so inhalers, spacers, face masks, mouthpieces, peak flow meters, and checking that we had enough, or how many the surgery should have at a time. So thinking about next steps, so obviously we'd really like to complete these clinics within all practices within Hillingdon. We'd also, as Alison alluded to earlier, is launch a Keep in Touch forum, and an email's just been sent out to all the practice nurses who participated in the role modelling clinics up until now about this. So the aims of this are to stay connected, to continue with annual meeting dates for education, and to stay up to date with the most recent guidelines. We will also be sending an email out shortly about the change to weaning plans as well. So I'll talk a little bit about the impact of COVID-19. So unfortunately, clinics were suspended in March and April. I think the reasons for this was that GP surgeries understandably didn't want extra clinicians in the practice. They didn't want extra patients in the practice unless absolutely necessary. I also think we didn't quite have the IT infrastructure completely set up at that time. However, from May onwards, we were able to resume the asthma clinics on a virtual basis. And now some face-to-face consultations have also resumed, depending on the practice and depending on patient preference. And whilst COVID did present lots of challenges and lots of difficulties, actually there were a few opportunities. So practices were perhaps more willing to engage in this programme because they had more practice time, nurse time available, whilst their routine work had been suspended during COVID-19. Parents were also more flexible with virtual appointment times as they were often working from home, and children weren't physically in school at the time either. So we have managed to continue the clinics from May onwards, and we're gradually having more face-to-face appointments. I think that's the end of the presentation, so hopefully we can answer any questions you have in the question and answer session.
Sorry, I've frozen again. Thank you very much, Alison and Anika. It's great to see some of the work that you've been doing, and I know that a lot of us feel like we would like to be able to do that work, but manpower and time is difficult. So hopefully this will give some of us inspiration to try and make change and see what we can do in our local areas. So I think now we're going to listen to Natasha.
Hello, my name's Natasha, and today I'm going to discuss with you guys how we've sustained the 48-hour telephone triage service in Islington. As some of you may be aware, that Whittington Health Paediatric Primary Care have been facilitating this service in the form of a telephone triage since 2018 for both Whittington and UCLH patients. I thought it'd be helpful, first of all, to give you a snapshot of the 2018 data and just talk about some of the things that we identified. We looked at data over a period of September to November and analysed the nurse activity for all patients that attended ED. In total, over those 3 months, we had 165 referrals, both from Whittington and UCLH, and in that time, 57% of patients received a 48-hour telephone triage by our team, and 15% received a 48-hour telephone triage by the GP. Just in that time frame, you can see that 57% is nearly double what the national average was of 28% following the NRAD report. So already we knew that we were achieving great data.
Natasha, sorry to interrupt you. You're sharing slides. They haven't come up on screen.
Oh, they're on our screen. It might be a bit of a delay. Hold on. Can you see that?
Just give it a moment. I think they're coming. Yes, here we are. Yeah.
Okay, so this is just an example of the tool. Sorry, guys. So this is an example of our tool. It's easily set up. So you've got symptoms, you've got progression, salbutamol, and peak flow age appropriate. So this is the triage tool that would come up. It's populated on EMIS, and following the consultation or throughout the consultation, given the questions that we've asked, it generates a score. And with that score, we then direct the patient appropriately, whether they need to be seen back in ED, GP same-day chest review, or if they've been coded as green, we have categorised them as safe to stay at home, and they will then be offered a face-to-face appointment with one of our specialist team at the next available opportunity. The next slide is just a little bit of how we categorise the code, so score of 4, 2 to 3, or 0 to 1. Following our PDSA cycle, we have identified some minor changes on how the score of 0 to 2 is, because I find that sometimes the patients, if you triage them sooner to discharge, they may not have weaned completely off of the wheeze plan, or they may still have a symptom of cough. So we've identified that 0 to 2 may still be a category of green. So we're looking to update the performer shortly. So just a quick snapshot of the data. So it's safe to use. It correlates the patient correctly. There's no adverse outcomes or evidence of harm when using the tool. We're achieving double the national average. It's cost effective, reducing reattendance rates and admissions. It's highly rated by our patients, and it makes patients with asthma safer. Just looking at a few statistics, any child receiving a 48 hour is 2.5 times less likely to reattend ED and 3.8 times less likely to be readmitted within 7 days of discharge. I'm just going to hand you over now to Eleanor, who's done our data analysis for 2019.
Hi, so as Natasha's previously mentioned, we took a snapshot in 2018 from September to November to measure the effectiveness of the initiative and how well it was working. And so what we decided to do was to do a comparative data comparative data analysis for 2019 from September to November in 2019 to measure how well we're sustaining the review and if it is still safe to use and being an effective way of treating patients. So in 2019, from the 1st of September to the 30th of November, we received 118 referrals from ED for children with asthma and viral-induced wheeze, and that's a combination of both Whittington and UCL patients. We also noted that, like in 2018, about 2/3 of patients were attending for wheeze as opposed to asthma. And we've also started looking at how many patients we have been capturing that would have been eligible for our service. So approximately, sort of our preliminary data shows that we've been capturing about 76% to 80% of patients that should have been referred to a 40-hour review with the PPCT. So this is just an overview of the outcomes. So overall, 67% of patients that were referred for a 40-hour review had a successful telephone triage with the PPCT, and 11% of patients had a successful review within 48 hours approximately with their GP, which shows that we are still reaching well and above the national average and approximately double that. As well as this, we want to look at when patients are being seen face to face as well. So on average, for patients that were triaged as green, they were seen on average of within 30 days of the 48-hour review. They were seen face to face by a healthcare professional. And for patients triaged as yellow, this was slightly reduced, about an average of 24 days, and red patients were seen immediately because they were sent back to ED. Of all the patients referred to the 48-hour review, no matter whether they received a successful telephone triage, they were always offered a face-to-face appointment within our team, unless they were already due to be seen with a secondary care service. And of the patients offered, 95% received a face-to-face review. We also picked out in 2018, more patients were triaged as green and then yellow, but obviously in 2019 you can see that slightly more were triaged as yellow than green, and this may be in part due to what Natasha was mentioning about the score slightly being skewed by the fact of people having longer weaning plans. The other important thing to look at is not just that we're reaching more children than previously or the national averages suggest, but that the tool is safe and that there aren't any adverse outcomes attributed to doing a review over the phone. So what we looked at was the patients that were triaged by our team using our tool, and whether they re-attended acutely within 7 days of their original discharge date from hospital. So what we pulled out in 2019, that there was one patient who was who had a green triage score that re-attended within 7 days. However, looking back at the data, we saw that this patient was also seen face-to-face by the GP at this point on the same day as our review, and there were no signs that they needed to re-attend ED, and therefore no suggestion that there are any adverse outcomes attributed to the tool. There were two patients that we triaged as yellow who re-attended ED, and this was following a referral for a same-day GP appointment, and then they were appropriately referred to ED by the GP. And there were two patients triaged as red who appropriately were sent back to ED following the telephone triage with the primary care team. So overall, I think what this shows is that in 2019, we have maintained reaching double the national average for completing the 48-hour review, and that our tool is safe to use, and that there are nil adverse outcomes attributed to using it.
Thank you, Nelly. So just quickly, a bit of information of how we've worked during the COVID-19 pandemic. Following the business continuity plan, the 48-hour review was deemed an essential service. We were allowed to continue. Unfortunately, the other clinics that we would facilitate alongside this were closed, as GPs did stop external staff from entering. We actually changed all of our clinics completely virtually from March 2020. And as UCLH ED department closed, patients were redirected to the Whittington. We did think that there were going to be an increase in referrals. However, we did see a significant reduction in patients presenting to ED. And I think this was due to the fact that parents may have felt anxious around the COVID pandemic and attending hospitals. And we do know that some patients didn't present when appropriate. Following the clinics changing to completely virtual, we were able to unfortunately not see patients face to face following the review, but actually maintaining contact more regularly via telephone. And actually we felt that that still contained that family, as we were able to review inhaler technique, we were able to review peak flows, we were able to look at chest. So the patients and parents did still feel that they were able to be contained during that time period. One of the things I'd like to also add is that the DNA rates definitely reduced due to the fact that we were able to contact people virtually, which is a really positive sign, and looking forward to potentially new ways of working. I think we will definitely continue virtual clinics in some shape or form. And then just lastly, just in summary of the 2018 to 2019 data, it is obviously preliminary at the moment. We are looking at finalising it, but we've identified that we are continuing to reach over double the national average recorded by Asthma UK in 2018. Our results show that the triage tool works and it appropriately determines the correct place of care for our patients. The tool is safe and nil adverse outcomes were identified. And the tool correctly identifies patients who need to be reviewed the same day. And one of the interesting things was that sometimes when patients are discharged from ED, they may not access their GP within a timely manner, and they may get lost in the net until they potentially re-attend ED. So we're able to identify the patients that are at risk and be able to review them in the community much better. Without them returning to an acute setting. Our relationships with GPs are definitely growing and our profile is being recognised, and we are actually being nominated for 3 categories in the upcoming 2020 Nursing Time Awards, which is brilliant, and we're currently publishing our data as gold standard for asthma care. Thank you.
Thank you.
Thank you very much, Christine and Natasha. That's great to see that we have got a good tool that we can all use to be able to run 48 hours, because I know that a lot of us are concerned that this isn't happening within primary care. So it's a great source that we can all maybe try and work from. So I don't know if we could have all of our speakers back on screen now. If you can put your videos back on, the speakers. And I don't know if anyone's got any questions that they would like to ask any of the speakers. If you could put your hand up if you have any questions. I think while we're waiting for that, I'll just go back to some of the questions that people have popped up. One of the things that wanted to ask Natasha was and Christine was, with your families that are uncontactable, what's your normal process pathway do you follow if you're not able to contact the family?
So just sorry, it's Eleanor.
Oh, sorry. No way, I've got Eleanor. Sorry, Eleanor.
That's all right.
I'm just reading the screen as well. It comes up as on the screen. Sorry.
So with the patients that are uncontactable, we do try. So once we've called, we check multiple interfaces. So we've got EMIS, we've got Medway. Usually 80% of the time that the contact number that's listed on Medway, because they've just had a recent admission or attendance, it's an up-to-date telephone contact number. So what we tend to do is if they don't answer, we always leave a voicemail, and we do tend to try calling again that same day. If we've been unsuccessful on both of those occasions and they haven't called back, we always send a letter to the home address advising why we've called today, advising what follow-up appointment has been arranged, and a contact number should they want to discuss going forward. And we found that a very high percentage of parents and children attend that appointment following the letter if they do not answer that phone call in the first instance.
Okay, that's great. And somebody else has also asked Natasha, what platform do you normally use for doing your face-to-face consultations with your families?
So one of the definite changing points for our service in 2018 was having the access to use EMIS Enterprise. This is the GP interface, but having the enterprise access allows us to have availability to every single GP practice in the Islington Borough, so it's not restricted to one practice. This has absolutely transformed the way that we engage with our parents and our consultations. The GPs can see our consultations as soon as we save them, and we can have access to their medications. So I feel like it's much more transferable when you're working alongside GPs in the community. They're aware of what we're doing and can follow our plans. So yeah, EMIS is definitely changed our service completely.
That's great. So I think we've got another question for Pippa, which was about the home spirometries. And just wondering, maybe for some patients that haven't done spirometry before, or those that have, do you get them to come in to actually go through the home spirometry before allowing them to do that at home?
We wouldn't get patients in purely to show them how to use the home spirometry. The majority of our patients will be quite familiar with spirometry from pre-lockdown, coming for regular appointments. But I do know that, so we've got a great physiologist team who send out the spirometers. They do online face-to-face training if need be. They also send sort of really clear instructions on how to use it, set up their app, set up their phones with the app. So it's a bit of a team sort of approach to making it all work. But for the majority of our patients, the actual technique, they're quite used to doing it, and those where the technique isn't good, we can see when the results are uploaded that maybe it's poor lung function because technique's bad, and the physiologists or sometimes us the CNSs will call and sort of watch them do it over the phone and over a video call and give a bit of assistance. Hope that helps.
The majority of the home spirometry I know in at Bart's Health is being used for those that have cystic fibrosis and those that have bronchiectasis, and I think that is the pure reason is that they know how to do lung function so well that it's so easy to manage at home. And we know that with our asthmatics, that only the ones that are in secondary and tertiary care actually do lung function, so it could be a problem for a lot of children that haven't done lung function before. And I think maybe a question to everybody, I've been a bit slow with actually doing the uptake of the video consultations because I think that a lot of my families struggle to speak English. Has anyone had any issues with patients actually accessing the online face-to-face consultations, or does everyone feel that it's going swimmingly well?
I'm happy to just answer that and say, I mean, all our biologic patients, we haven't had any problems. Everyone speaks English. There's no issues. But just in our day-to-day, we occasionally have patients where English is a problem. And we do, I admit, really struggle. We've had difficulties with translators sort of online as well. It's difficult. And in most situations, we feel that we actually need to get them up for a face-to-face. But I admit for us, it's far and few between. It's Tori, if you've got lots and lots of patients, that defeats the objects of virtual, I know. But for us, we have resorted to having to bring patients up.
Yeah, I'm trying my first clinic on a face-to-face platform next week, but I'm actually doing it with the health advocates because I thought at least then they can explain to the family how to log on and how to do it all. So I'm going to try and see how it goes. So maybe I might use it more. So if we look, we've got hands up from, is that Simmons or Ashira? Do you want to put your question to
Yeah,
ask?
hi. I use NHS Attend Anywhere as a digital platform, and we use interpreters quite often, and they log in the same way as a parent does, and then we're able to do a three-way conversation with the families, and we're able to do face-to-face, and the consultations have gone really well just by using that platform.
Well, that's good to hear because that's the one I'm going to use. So hopefully it will work out next week. We've also got Emily, if you'd like to put your voice on so we can.
Hiya. I was just going to say in Newham we have a lot of the similar population as you do, Tori, as you know. Our interpreting services run a three-way face-to-face Zoom platform for interpreting, but sometimes that's not so easy for the families to access, and when that happens, we tend to bring the interpreter in with us, and then we do a call out to the families if they're struggling with technology.
Yeah. I think that although technology is good and it's helped us with, well, it's helped me with my DNA rates because people are answering and they're not DNAing, which is a good thing. But it does can be difficult for some people to access and use, and obviously that is higher in areas where there's more deprivation, that they maybe don't have access to mobile phones or computers and laptops. So I think it's a good way forward, and I think it's a good that we're able to be quite diverse and use lots of different aspects. And I will be using more virtual ways of discussing patient contact rather than face-to-face, purely because of the DNA rate. But there will still be issues where you need to have that face-to-face, especially with child protection issues or compliance issues as well. So I don't know, is anybody else got any more questions? No, does any of our speakers have anything else that they wanted to add or anything at all? Well, I think we've done good to time. So I think I was going to just say a few words and just say thank you for everyone attending and spending this time to help promote Ask About Asthma, and for our speakers to designate their time to share what they're doing in their services. And I just wanted to say that I'm very proud to be a nurse, and that we've all shown how resilient and adaptable we are in this crisis of COVID, in changing our ways of working, and using digital working, which not all of us or maybe as good as others at using. So I think we've done a really good job of doing that, and asthma services have been developing. It's getting stronger in paediatrics, and there's a lot more of the services improving. So just wanted to make sure that everyone keeps up the good work, and make sure we continue spreading the rest of the week of Ask About Asthma. And if you can do tweets to share some of that information. There will be more podcasts and webinars out for the rest of the week, so please keep updated with viewing all of those. And if you could please make sure that you fill out the monkey survey, which has been enclosed within the chats, and I think also the girls will email it out to you, so please make sure that you can fill those out for us. Okay, so thanks everyone for coming, and I hope you enjoyed everything.